So with that, I want to start this very important broadcast. Again, heart health is so important to the Indian community and the Asian American community and the South Asian community specifically. So if all of you could mute yourself, please. Uh, and in my own family, we've had so many episodes and occurrences of this. Unfortunately, I lost my father at a very young age. He passed away just before he turned 60 years old due to cardiac arrest. And in my family, my brother, my sister, many people in my family also are going through really tough experiences with their heart conditions. This is, I'm sure, endemic to a lot of you listening to this broadcast as well, and your families and are also involved in this issue. So we thought we would make this a major broadcast, and to start and kick this off, we have our good friend, Dr. Vivek Murthy. Vivek was a Surgeon General not once, but twice in two different administrations, non-consecutive, and he's the only Surgeon General to be Surgeon General in two non-consecutive administrations under two different presidents, and the youngest flag bearer as a Surgeon General. And Vivek exemplifies our community's service, or seva, as we call it, selfless service, by doing public service. He's not only an MD, but also an MBA, participates actively in public life, public policy, and was also in.
Indra, do you want to watch this, Indra?
So, could everyone mute yourself, please? And we will have.
I did not get my headphones.
Vivek come up and make some opening remarks, and then I'll have a couple of questions for him before we move on to that panel. So, Dr. Vivek Murthy, the former Surgeon General, welcome.
Well, thank you so much, MR. And it's wonderful to be here with all of you. I want to just, from the start, just thank MR and Indiaspora for bringing us together for this call, and MR for your friendship and leadership for our community over the years. And I also just especially want to recognize the South Asian Heart Center, which has really done an invaluable service to our community by making sure that we are increasingly focused on heart disease in the South Asian community. Now, I know that many people on this call know folks that you love who have developed heart disease, and often at a young age. And we may have wondered, like, why has this happened to our family members? We think that they're relatively healthy. They seem quite young. They seem to have lifestyles that are similar, if not better, than many of their counterparts from other communities, yet they have fallen ill. And I had a similar experience in my own family. My uncle Subhash, who lived in Bangalore, we loved him dearly. He was a comedian in our family, really. He was the youngest in his generation, my mother's generation. And he was the one who, whenever we went to India, all the kids in my generation loved him. We always wanted to be around him growing up. And he was also quite healthy, or so we thought. And that was until one day when he was in his 50s, he had this sudden onset of chest pain. And within a few hours, we had lost him to a catastrophic heart attack. And for many of you who have family back home in India or in Pakistan or other parts of South Asia and are living here in the United States, you know how terrible and awful it is to get that call from the homeland and then to hear the terrible news that you've lost someone. And I still remember that day when we heard about Subhash passing away. We know that South Asians have a higher risk of heart disease than their Asian and white counterparts. And they also tend to experience the consequences of this at a younger age. But the truth is, right now, when most people go to the doctor, they don't receive education and care that takes this into account. And the truth is, we've got major gaps in our knowledge, but also real gaps in understanding among not just the public, but among clinicians as well, among doctors and nurses who are taking care of South Asian patients, but may not realize that they are at an increased risk. And the result of all of this is that many South Asian families end up suffering the pain of illness and loss. Now, I'm grateful that this is starting to change, and that's thanks to the dedication and commitment of clinicians and researchers, including those on this call, and especially the people you're going to hear from on the panel later this hour. It's also changing because of organizations like the South Asian Heart Center and Indiaspora and others who recognize this is something we've got to bring to the attention of people in our community. Now, we've got a few things to do. We have to advance our understanding of why our community has a higher heart disease risk and what we can do about it. That's why dedicated research is so important. we also have to make sure that our elected and appointed leaders who allocate resources for both research and clinical care, we've got to make sure they understand that the health of South Asians must be a priority and can't be assumed to be the same as the health of every other racial and ethnic group. And finally, we've got to ensure that our clinicians and communities understand this increased risk so that we can take action early to help reduce our risk and thereby save lives. So today's conversation represents a really important step toward these goals. And I'm so glad that all of you are joining. Please, after this conversation, take time to talk to your family, to your friends, to share with them what you learned today. And hopefully together, we can work toward a future where South Asians have a lower risk of heart disease and where they're healthy, happy, and deeply fulfilled. So with that, let me turn it over to MR. And I know we're going to get into our panel soon.
MR, you there? I think MR may have had some connectivity issues. Let me just, Dr. Murthy, if you don't mind waiting for the next few minutes, we'll
Sure.
just give MR a second. But in the meantime, we would love to bring on the panel if possible. We will start with Dr. Gulati, and then Dr. Mathur.
I'm here. I'm here.
Okay. Okay.
Amita, sorry about that, Vivek.
It's okay.
Technology kind of reared its ugly head and I was knocked off. But
No
thank you
problem.
so much. I was listening in and I dialed back in. So first question is, I know you talked so vulnerably about your uncle, and this is a condition every one of our family faces. I know you've also written a book on loneliness that we had you talk to our community. Is there some relation to loneliness and heart health and health in general? Can you talk a little bit about that as well?
Yeah, thank you, MR. And I think one of the things that we have recognized over time is that, our physical health is deeply connected to our mental health and to our social health, as well as our spiritual health. These four dimensions of our health combine to contribute to our overall well-being, but they also interact with each other. And so when it comes to our social health, when we don't have healthy relationships in our life, when we experience a sense of loneliness and social disconnection, that in turn actually has a real effect on both our mental and physical health. It turns out it increases our risk of depression, anxiety, and suicide, but it has real effects on our heart as well. So we see among people who are socially disconnected, who are lonely or isolated, we see about a 29% increase in the risk of heart disease, a 31% increase in the risk of stroke, a 50% increase in the risk of dementia among older individuals. And the overall mortality impact, you can think of that as like the life-shortening impact of being socially disconnected, is on par with the mortality impact we see of smoking or obesity. Now, I say that as somebody who had the privilege of serving as the steward of an office, the Office of the Surgeon General, that for generations is focused on tobacco and obesity as critical public health issues. But it turns out that loneliness and isolation are just as important, and they contribute mightily to our physical as well as our mental health.
And then I'm sure the panel will go into in-depth more issues as well. So what do other non-communicable diseases, what role do you think they play as well, right? There's diabetes, there's hypertension. So when you were Surgeon General, I'm sure these were general issues you had to deal with. Any words of wisdom for our community from your experience?
Yeah, I think, and I know our panel will get into this, but I think the more we learn about health in general, the more we realize that, our health is deeply connected, that diabetes and high blood pressure, and the risk of heart attacks, that there's a link between all of these. These aren't all separate illnesses that don't interact with each other. And we do see an increased risk of heart disease in people who have diabetes. We see an increased risk of stroke and heart attacks among people who have high blood pressure. And so what we see in the South Asian population also in particular is that if you take two individuals who have the same BMI or body mass index, for those of you who are familiar with that term, it's a term that uses a combination of your height as well as your weight to calculate this metric that gives you risk. And we know that South Asian people tend to have an increased risk at lower BMIs than their white counterparts. Now, why is this important? Well, because if you go to the doctor and the doctor checks your BMI, how do they know if you're okay or not, if you're in a low risk category or not? Well, if they're using the traditional cutoffs, which were largely applicable to white individuals, they might say to you, hey, everything's fine, there's nothing to worry about. But if they knew that at lower BMIs, that South Asian people can still have higher risk, they may manage you and advise you differently. So these are all very much interrelated. And the more we learn about metabolic health, the more we realize that our diet, our stress levels, our exercise, our environmental factors, as well as, of course, our genes, all come together to impact our risk of these different conditions.
Fantastic. And I know you just finished your term as Surgeon General just a few months ago. So I'm sure the audience is kind of curious, what's in store for Dr. Vivek Murthy in the future?
Well, I'm taking some time to figure that out. I'm building a portfolio of work bit by bit. Some of it is focused on some of the issues I was focused on in office around how we can rebuild a sense of community in our country and actually around the world, recognizing that issues like loneliness have become rampant, not just in the United States, but in Europe and South Asia, in Japan, in Australia, and many parts of the world. I spent some time in India actually in October of last year while I was still in office. And, I will tell you that sitting in Bangalore and Bombay and doing roundtables with students, if you had blindfolded me and changed people's accents, I would have thought that I was talking to students in Lincoln, Nebraska or Los Angeles about the youth mental health crisis because they describe the same types of struggle with their mental health and well-being, the same struggles with social media that kids here are experiencing and contending with. So there is more that we have to do to rebuild social connection, and it's vital for our mental and physical health. And so I'm working on some projects to help take our work to the next level and really build the next chapter of that to build it into a broader global movement. And then, well, the most important thing that I'm trying to do during this time is I asked my kids, by the way, before I finished as Surgeon General, what I should do after I'm done. You're at a desperate point when you're taking career advice from a 7 and 8-year-old, by the way, but that's where I was. And they both said the same thing to me independently. They both just looked at me when I asked that question and they said, I think you should spend more time playing with me. So I'm trying to do that as well. More drop-offs, more pickups, more playtime with them, more listening to them, more story time. I love to make up stories and tell them to my kids at bedtime. So that's been therapeutic for me. It's giving me some time to process, but I'm very excited about building this broader movement for community and connection. I think it's vital not just for our health, but it really impacts every other dimension of our life. When people are more connected, they're more productive in the workplace, more engaged, more creative. When kids are more connected to one another, they perform better in school, and their performance after graduation is also better. And if you're out there and you're worried about the polarization that you see in our country and the division, it turns out that is also deeply impacted by how connected or disconnected we are. So it turns out that these connections that we enjoy with one another, they're as vital to our health and well-being as individuals and society as food and water. And they've been deteriorating over time for a variety of reasons. But this is our time for us to rebuild them, to strengthen them so we can be better and well for now and for the future.
Thank you so much, Vivek. I know you've done exemplary public service for not just the Indian American community, but America at large. Oh. And on behalf of our community, we want to thank you for that. And we look forward to seeing what happens in the future with the exciting work you're doing here as well. So thank you once again.
Thank you, Amar. I'm very proud to be a part of the South Asian community and always want to do everything I can to support our community. So thanks for this opportunity to be with you tonight, Amar.
Thank you. And now on to our panel. I'm sorry, because of technical difficulties, I had Dr. Pradeep Natarajan's bio open in front of me, but I don't have it at the moment. All I know from past encounters with him that he is at the Mass General Hospital. He also works at Harvard. But more importantly, I think Dr. Pradeep Natarajan has a huge project that's funded to do genomic studies on South Asians as it relates to their cardiovascular condition as well. So Pradeep will now head up an esteemed panel of people from across the US. Again, this shows the talent and the public service nature of our community to get people from all across, cardiologists and health experts, all across the US to come together on this panel that Dr. Pradeep Natarajan will now moderate. So Pradeep, over to you.
Thank you, Amar. Thank you so much to you and all the organizers. Very excited to get this group of leading experts on this topic, and definitely to Dr. Murthy for overall his service and calling attention to many, many important public health issues, including this one that is near and dear to many of us. Now, it was very clear to me early in my life that cardiovascular disease is very common in the community. You'd hear many devastating stories like the one that Vivek had mentioned and MR had mentioned. And these were all too common. And, that thread early on carried through. This is why I direct the Preventive Cardiology program at Mass General, and I'm a researcher at MGH and Harvard. But as I had completed through, and I really wanted to come back and study why South Asians have a high rate of cardiovascular disease, it was quickly obvious that we did not have the research infrastructure to address those questions. Now, in this panel, we'll talk a lot about what is known about cardiovascular health, what do we know about differences among individuals of South Asian descent, and what we can start to do it based on the available data that we know today. But there are really important knowledge there. And so I'll post a link to the study that MR had mentioned. It's called the Hour. Sorry, okay, I was muted and now unmuted. So it's supported by the community because, as Vivek said, we have to remind our federally elected officials that this is an important issue for our community. It may not be exactly the same across other communities. So as it stands right now, it is supported largely by philanthropy and the participation of others. So with that, I'd like to call to the forefront our panelists. We have Dr. Latha Palaniappan, who's the Associate Dean of Research at Stanford University and co-founder of the Stanford Center for Asian Health Research and Education. Dr. Rajesh Dash is the Associate Professor of Medicine and Preventive Cardiologist at Stanford, where he started the Stanford South Asian Translational Heart Initiative. Dr. Martha Gulati is a Professor of Cardiology and the Director of Preventive Cardiology at Cedars-Sinai. And Ashish Mathur is the co-founder and executive director of the South Asian Heart Center at El Camino Health. Welcome. All right, so I have a list of questions, but I do want to make sure that we have enough time for questions because questions are coming through from the audience, and I encourage please put them in, and we'll spend time at the end. So we'll get through as many questions as we have, but your questions are also just as important. So first question that I have, I'm going to direct it to Dr. Palaniappan. So the American Heart Association, in conjunction with the NIH, annually publishes a really important document, probably the most cited document among cardiovascular researchers. These are the most up-to-date statistics related to heart disease, stroke, and risk factors. And Dr. Palaniappan was the chair of that document. So can you summarize for us, how are we as a nation doing for cardiovascular disease?
Thank you, Dr. Natarajan, and I want to echo the thanks to MR for bringing us all together today, and thanks to Dr. Murthy for your service to this country and your really compelling story that you shared with your family. I'll also share that my father died of a heart attack at age 39, which is what got me into my business. And I think that we all struggle with looking at the literature and really finding information on our communities. And I will say, of the 620 pages in the American Heart Association statistics update, South Asian is mentioned 27 times, in contrast to 608 times that white is mentioned. So I will say that whatever we know about heart disease is in white populations. Despite the fact that Europeans make up 9% of the world's population, they are 90% of the genetic databases. And South Asians make up 1 out of 4 people on the planet, and only 1% of genetic databases. We have spent $200 billion studying heart disease in European populations. Of that, 0.17% is for all Asians in general, that make up 60% of the world's population. So I'll stop my comments there so everyone can get a chance to speak, and I'll drop a link to the 627-page document in the chat. Thank you.
Thank you. Dr. Gulati, you were just the president of the American Society of Preventive Cardiology. Can you generally summarize the role of modifiable cardiovascular disease risk factors, health indices, who should be screened, how often, when?
Yeah, so quickly, I mean, we should be screening everyone and everyone should know if they're at risk for heart disease. Of course, the way that we assess risk currently, again, the same problems exist. South Asians have been clumped, if anything, they've been clumped with Asians, but in reality, and Asians, but what I mean by that is that we are not the same necessarily as people from Chinese descent or Japanese descent, etc. And yet we're clumped together. Even some would argue that South Asian is too broad of a term as well, because there's very much differences depending on different backgrounds as well, just within the South Asian community. As a result, whenever we calculate risk or use our risk scores, you will see that when you plug in other as a race, we are just defaulted as white. And we know that that isn't true. I mean, we know that the risk is much higher in our South Asian community. And so I hope that the message to everyone listening is be screened. As an adult, you should know if you're at risk for heart disease and share that with your family members. Everyone should know we're at much higher risk at an earlier age. Otherwise, we wouldn't all have these stories. I'll just to add so that everyone knows everyone's story by the end of this. In my family, women didn't live past the age of 50, and that's why I study women and heart disease, because all the women in my family before the age of 50 would die from stroke. And me and my sister, I guess, will admittedly have crossed that barrier, and we celebrate that every day. So thank you.
Thank you. I'm going to go back to Dr. Palaniappan. The traditional modifiable risk factors have been, blood pressure, smoking, cholesterol, diabetes. There's rising interest in overweight and obesity because of the rising prevalence, but also medicines. But just, can you tell us a little bit about the extent to which obesity is now driving cardiovascular disease? And important to recognize, as Dr. Murthy had said, that may not be the best marker of adiposity or fat distribution related risk in South Asians.
Thank you for that question, Dr. Natarajan. An excellent point, Dr. Murthy, that the body mass index recommended for South Asians in general is 23 and lower, and for white populations, it's 25 and lower. And that means if I gain 5 pounds, that I am overweight according to South Asian standards. And I just returned from giving talks for American College of Cardiology in Delhi, Mumbai, Chennai, and Kathmandu, 400 people in each of these audiences. And I was surprised by the food choices that doctors have at conferences in India, lots of fried carbohydrates, which we would not recommend for our patients and hopefully not consume ourselves. So I think we have a long way to go in terms of addressing modifiable risk factors. We're looking for the magic bullet, and I still am. For 25 years, I thought I would have figured it out by now, what is different in South Asians. And I hope that with our health study, we will be able to figure it out, having a combination of genetic and lifestyle factors on 10,000 South Asians will be critical. And I encourage you to look at the link that Dr. Natarajan posted on our health. And I encourage the 200 people on this call to join that study. You just have to fill out an online form, and then you'll get a saliva kit that's mailed to you. And we really need to work together to increase the knowledge that we have in South Asians. But in the meantime, work on the modifiable risk factors, because 70% of the people in the US are overweight or obese, and the number is ever increasing in South Asia as well. So, and then also once you've hit the 25 and lower, realizing that for South Asians in particular, it needs to be 23. And then I've done studies showing that increasing muscle mass, so strength training is much more important for South Asians because we are born with less muscle mass in general. and 80% of the insulin-mediated glucose uptake in the body is through muscle, through GLUT4 receptors. So we need to increase muscle. So focusing on muscle strengthening when you have the choice between aerobic and muscle strengthening exercises. I'll post the link to that paper in the chat as well.
Great. And Dr. Reddy actually posted a nice comment about waist to hip ratio potentially being better than BMI, which we know is generally true, but probably even more relevant for individuals who are South Asian. Dr. Dash, you direct the the Stanford South Asian Translational Heart Initiative, SATI, and we've been talking about very compelling emotional anecdotes, in our own families, our own communities about cardiovascular disease in South Asians. Has this been quantified, or what is known just about the elevated risk?
Yeah, thanks, Pradeep, and just want to thank MR and Indiaspora for inviting me. It's an honor to be here with people that I've taken inspiration from, including Ashish and Lata, whose fundamental research really inspired Sati's origins. But yeah, let's quantify. Let's add some numbers to the problem a little bit, and then also talk about the risk factors that may be driving that elevated risk that aren't captured by traditional risk scores. Right now, again, Lata, you published a while ago, 4 times the rate of cardiac events for South Asians living in California, right? That's a huge number. And when we have our first heart attacks as South Asians, it tends to be 11 years younger than the general population would. 11 years younger, and yet our mortality from that first heart attack is 40% higher. So what's going on? What's accounting for this? If you look at the 10-year risk scores, the Framingham risk score, AHA Prevent, whatever it is, and you superimpose South Asian scores versus non-South Asian scores, they're almost identical, but the rates are so much higher in terms of events. So we're not able to capture that with traditional risk scores. So where is that risk coming from? And our clinic kind of looked at this in a way, what could we test that was non-traditional that we could actually treat medically? And we had to develop our own algorithms and care pathways. And so what are those buckets? Those buckets of risk that we think are really sort of outsized in the South Asian community are insulin resistance and prediabetes. So we do a 2-hour glucose tolerance test with insulin for all of our patients, and 70% of our patients have moderate to severe insulin resistance. Half of them have prediabetes, and they're only 42 years old on average. So this is a huge driving force for increased inflammation, which is the second bucket of risk. Inflammatory markers like apoprotein B and lipoprotein(a) are significant contributors to the higher rates of heart attacks and strokes, and yet almost never are being checked in the general population. Less than 1% of patients in the US have had an Lp(a) drawn. And then, particle sizing. We tend to have lots of small particle LDL that is more atherogenic, that can lead to more plaque growth. And anything that makes plaques change in size makes it more unstable, and unstable plaque leads to more heart attacks. So we have sort of several different disadvantages. And so if we can actually capture that risk when we're screening for both traditional risk factors and add some non-traditional risk factors that we can intervene upon, that's exciting. Now, some of these haven't had drugs that could help directly target for many decades, but soon that's about to change. So there's some exciting things on the horizon of how to manage this, but we really do need to have combinations of lifestyle and medical therapy to really drive down the rates of heart disease in this community.
Yeah, Dr. Dash, you brought up an excellent point. These 10-year risk scores that you alluded to earlier, that's the way that doctors kind of try to estimate or forecast cardiovascular disease risk, and that helps allocate therapies. But the scores basically will give you the same numbers as far as predictions for South Asians and non-South Asians, but empirically the event rates are different. So it's just not capturing that. And you've highlighted some of these additional indices, and we'll come back to lipoprotein(a). Lots of questions are coming in for that, and I'll come back to you on that. But just on this theme on kind of tailoring risk reduction and risk management in South Asians, Ashish, your center has been called out. You co-founded and you're the executive director of the South Asian Heart Center, the first of its kind, trailblazer. Can you tell me a little bit about the history of starting the center? Why did you start it, and what kind of tailored care is provided? I think, Ashish, you're on mute. Ashish, you're still on mute.
Yeah, thank you. Thank you for that. And MR, thank you for hosting this and putting all the minds that have been working on this issue together for literally the first time. So it's really great to see everyone here and to talk about this particular issue. You know, as a community, we have long focused on clinical risk factors, cholesterol, calcium scores, BMI, blood pressure. But we often ignore the risk that we know about, and that is of being South Asian. We've heard so often that, you know, South Asians are at a greater risk, and yet we the yardstick that we are measured with is somebody else's yardstick. And so, despite strong family history, there is deep under recognition of this risk within the community, as well as in healthcare. Delayed prevention and cultural norms that equate rich food with love. It's a perfect storm. I know it because I've lived it. At 44, I had a heart attack. No symptoms, no warnings. I didn't smoke. I wasn't overweight, walked daily, and still nearly died. This shook me to the core. But what I discovered afterward was worse. The medical system wasn't built to recognize South Asian risk. So in 2006, we built what didn't exist, a new model for prevention. At El Camino Health, we launched the nonprofit South Asian Heart Center and aimed to prevent, the first program in the US tailored to South Asians, focused not just on detection, but on transformation. So what makes us different? You know, we treat lifestyle as the vaccine because behavior change is the most powerful medicine. We were the first to recommend advanced and comprehensive screening for South Asians. We have now created the SCORE tool and the ABC risk profile to classify this risk better from amongst the risk factors that we know about today. And we are really looking forward to your research and other research that's being done by this group of folks to better shed light on this. We deliver culturally competent, lifestyle-informed interventions, factoring in the food that we eat, the stress we carry, the sleep we skip, and the exercise we avoid. We bridge modern science with Vedic wisdom, with simple, powerful guidance. For example, more greens than grains, 2 fistfuls of vegetables a day at a minimum. And no, that's not potatoes or paneer. And we pair each participant with a trained health coach from the community, offering persistence, compassion, and credibility. So this isn't just prevention, it's a movement of urgent, culturally grounded care that finally speaks our language. We didn't wait for the system to change, we built what our community needed before it's too late.
Thank you. Now, Dr. Gulati, you brought this to the forefront recently for cardiologists more broadly. You co-chaired a very important document with Dr. Rohati at UT Southwestern, Dr. Patel at Johns Hopkins. It was a clinical practice statement about improving cardiometabolic health for South Asians. This was on behalf of the American Society of Preventive Cardiology. Can you tell us just a little bit, just summarize a little bit what was in that document? Why did you bring that together? And what are the insights that this audience can take from?
Yeah, well, it was a very big document, so it's really hard to summarize, but I'll do my best. You know, what we tried to do was identify clinically what can we do for our community and how can we prevent cardiovascular disease. And of course, it was a team effort with over 20 people participating, of cardiologists, other cardiologists with different areas of expertise. Basically, what we identified more than being able to guide people, the biggest part is identifying the gaps and where we need research to go. I think that, you know, I'm sure we'll talk about that, but I think that's been the surprising lack of data for our own community has really, you know, been a limitation for us to make a lot of recommendations. just to give some examples, we highlight some of the differences between South Asians and other populations. One example I'll give for anybody here who's a younger woman, for example, women of South Asian origin have much higher rates of gestational diabetes as well as hypertension during pregnancy. And then the complications of hypertension during pregnancy are greater acutely for South Asian women, even if it's more frequent in Black women. So that's just one example, but we are not yet knowledgeable about how to identify why it's occurring more in South Asians and how do we prevent it upstream? What can we do before? So I think there's a lot of gaps that we are still waiting for. But I think that the reason we put the document together was to give us a bit of a roadmap so that we could be talking more about prevention and also thinking and designing studies that may lead to better answers to take care of this population. There's differences if you're born in America as a South Asian versus somebody who's an immigrant from South Asia. And again, we don't entirely know the reasons for that. We have lots of data now, but we just don't have the research trials saying how do we improve your outcome.
Great. That's a great segue into the next question. Dr. Palaniappan, as Dr. Dash had said, you have been a longtime leader in this space in the research of cardiovascular disease in South Asians. How is the field kind of starting to try to address these questions?
Well, I think it's amazing that we've assembled this brain trust together here. And I will say that, when I was starting out 25 years ago, this would not have been possible. And I want to say that I am standing on the shoulders of giants. I just got to meet Dr. Mohan, who runs a diabetes center in Chennai, and really benefited a lot from his work. And I'm so glad to be in this sort of intellectual quest with all of you, because I know that these are the avengers of South Asians and heart disease, and in our lifetimes we'll figure it out, and we're just on the cusp of that. We just need a little bit more money to match what we've done with European populations. And I'm confident that the science is there, and we just need to focus our resources on this problem at this time. I've been enjoying the chat, and I just want to give a shout out to Dr. Nalini Selagram, who founded Arogya World, and she is really working to bring this science to the last mile in India. So thank you for your efforts there. And I just really want to emphasize that we really need larger cohorts of diverse South Asian populations. South Asians make up 1.4 billion in the world. When I was in India and Pakistan were at war, and it made it very logistically difficult, but I just realized that these countries that we group together in the United States are actually quite distinct, and quite distinct in terms of religion and diet and cultural habits. And we really need to understand this as we move forward in counseling our patients in the US as well. So I'll turn it back over to you, Dr. Natarajan.
Great, thank you. Ashish, back to you. A common recurring theme is that we're seeing lots of early onset prediabetes, diabetes, dyslipidemia as very important risk factors, often precursors to cardiovascular disease. How do you generally approach this with the patients that are coming through in your center?
You're absolutely right. Among South Asians, we often see prediabetes, diabetes, and lipid abnormalities showing up early and without the usual red flags, such as high BMI. And that, is problematic because you can't kind of work on weight loss to address these issues. That's because traditional models miss how deeply metabolic risk is wired into our genetics and lifestyle patterns, even in people who appear lean. Many carry the fat viscerally. We call it kind of the thin fat syndrome. At the South Asian Heart Center, we approach this with the urgency it demands and with a precision lifestyle lens. One of our most effective tools is the use of the continuous glucose monitor now, or CGM. It helps patients see for themselves how food, stress, sleep, and movement affect their blood sugar in real time. That insight often is life-changing. But we don't just stop at telling people what to eat. We personalize nutrition content, yes, but we also adjust the sequence, combination, and timing of meals. Because for our population, even the order of bites and the spacing of meals can shift the glucose dynamics dramatically. We also emphasize non-dietary interventions just as strongly. Strength training to increase muscle mass and improve insulin sensitivity. Sleep hygiene and meditation to rebalance the nervous system and lower the cortisol-driven glucose spikes. And critically, we take time to understand the culture and family environment, because food isn't just fuel, it's tied to identity, tradition, and social dynamics. If you don't explore that layer, the best advice often goes nowhere. Ultimately, we help our participants rewire their lifestyle, not with fear, but with understanding, relevance, and support. And that's what creates lasting change.
Wonderful. I think we're addressing actually a lot of the questions as they're coming through, but I'm keeping tabs of the ones that we haven't addressed. But one of the questions I'll direct to Dr. Gulati is about statins. Who should be on statins? We read a lot about statin-associated side effects. What's the evidence around that? And then I'm going to throw in one third question, just because some of this has come up, is what is ApoB and apolipoprotein B as a novel biomarker?
Yeah, again, to determine who needs to be on a statin, currently in the US, we use our risk scores, as we started out talking about, to determine somebody's risk, both their short-term and lifetime risk. But we do take into account risk enhancers. And as I put into the conversation, being South Asian is a risk enhancer. It's one thing we identify. We don't really know what to do with it at this point, but we always say that that's at least a risk enhancer. So perhaps using other type of imaging when somebody might be low to intermediate risk by the risk scores. Being South Asian, we might consider doing different tests to see if you're at a greater risk. That for me would include something potentially like a coronary artery calcium test that might help us identify somebody at risk for heart disease at earlier ages than the risk score would actually estimate. So the people that should be on a statin, first of all, if you have heart disease, if you had a heart attack or a stroke, or you have peripheral vascular disease or any form of vascular disease, you should be on a statin. If you are high risk by any risk score, you should be on a statin. If you have plaque in your arteries, you should be on a statin. And I think that the gray zone is the other people. So if you have elevated Lp(a), which is disproportionately high in the South Asian population, for me, the way that I practice, I consider elevations in Lp(a) to point to somebody being at high risk. And I do currently put people on a statin to lower their LDL cholesterol, because it's the only treatment that we have currently. I know that somebody had put in that we know how to lower Lp(a) a little bit, we do. But what we don't know from those trials is whether they improve outcomes. And those trials are ongoing currently right now, and we'll see what they show. But two important studies, one called the Horizon study and one called the Ocean A trial, will be released in 2026, and we'll see if we have a unique treatment for Lp(a). But in the meantime, lowering LDL is the target of our treatment and the most important thing. We do measure things like ApoB. You can measure ApoB, and you can also just calculate non-HDL, and both of them aren't wrong. Again, those are, when they're elevated, people may consider treating you again with a statin. I am not the biggest fan of somebody asked in the questions about NMR lipid profiles, like the size of the lipoprotein. Our guidelines currently point to them being potential risk factors, but we don't know how to treat them. Again, our targets of treatment are always LDL. I know people like more information, but I think that if we would just target people's cholesterol, if they just got their cholesterol panel and we were able to know that they're at risk, that would be helpful. I do think getting, as I said, LP(a) checked, and I do think getting high sensitivity C-reactive protein, I think those are useful things for everybody to know. And then working with their cardiologist, their preventive cardiologist, their primary care physician, whoever's managing them, to talk about what else needs to be done. There's always personalization. Pradeep has done a lot of amazing work at genetic polygenic risk scores, where they might point to somebody being at higher risk that even when they have no risk factors. And I think that's often the situation with our South Asian population is I'll get young people coming into my clinic. They have no risk factors. They may exercise regularly, eat a pretty good diet, they're thin, and there's nothing that is out of the normal, and yet they are at high risk for cardiovascular disease based on their family history. They tell us, look, people die before the age of 40 in my family. These are the people that I think we need to go a little bit further and try to identify if they're at risk. And I know we don't know every genetic variant out there, but I do think these can be useful tests. And that's why I just want to emphasize why our health study is so important, because I do think that the more we learn about our population, I'm sorry, this dog just hit over my computer. The more we know about our population, the more we will be able to treat them. Thank you, Coco, for making an appearance.
We always welcome more panelists.
Everyone. So,
just a reminder to mute. Thanks so much. Dr. Gulati covered quite a bit. Now, for lipid-related risk, we talked about very important to get your lipids checked. The LDL cholesterol is the one that is the target for statins and closely tied to cardiovascular disease risk. And ApoB, or apolipoprotein B, is kind of a more refined LDL-related risk, and there's increasing interest. Lipoprotein(a), or LP(a), is an LDL-like particle that you have to separately measure, just like ApoB, and some evidence that suggests particular relevance in South Asians. And there are ongoing studies to see if that is a modifiable risk factor. Lowering it can lower risk. And then the last thing, as Dr. Gulati had said, and I'm addressing this because there's some questions that are coming about this, is about genetic risk and genetic predisposition. We talked about family history as being an indicator, but that genetic predisposition can be increasingly refined in its quantification in so-called polygenic risk scores. Turns out these scores perform best when you have information that is coming from the represented population that you want to evaluate them in. So the scores are getting really good. They're actually clinically available scores. We have a clinical score. But one of the intentions for the Our Health study is actually to refine this for South Asians, because we think it will be even better in individuals who are South Asian. And I don't want to make any promises, but we are working through our IRB to actually potentially release scores through this study as a part of an ancillary study. Okay, now with all that together, I was planning on asking Dr. Dash about lipoprotein(a), but I think we've covered that. And a lot of questions about imaging, coronary artery calcium scoring, coronary CT angiography, stress tests. For risk stratification, asymptomatic patients, what tests do you recommend? Who should be getting these imaging tests?
So I can tackle that. And really, I think, the LP(a) story is related to the answer to your question. All of the things that we measure in clinic are not actually disease, right? They are risk factors to develop disease. The anatomy of the heart is really where you can find out, do you actually have plaque? Do you actually have calcified or non-calcified? And if you have non-calcified plaque, is it low attenuation, the highest risk type of plaque that could potentially rupture? These are emerging sort of biomarkers or actual disease characteristics in the plaque of the vessel within the heart that are becoming more and more a part of how we make decisions in cardiology, right? So when we are thinking around what your target LDL should be, if we know that you have clean coronary CTA, coronary CT scan with no plaque visible, you may have a target that's not as aggressive, right? As someone who has mild or moderate amounts of plaque, nothing severe, but like, what are you actually targeting your therapy to? I think as things like Lp(a) and other biomarkers are entering now, not just into the associated with heart attack type of world, but now we have a treatment that can lower Lp(a) potentially for you and has clinical trial data potentially that will show lower event rates. We have to start making decisions about who should get advanced imaging in the heart to show us that, yes, you have a high Lp(a) and you have non-calcified plaque. And there was a recent study just shown at the American College of Cardiology meeting that high Lp(a) individuals do have higher levels of soft plaque than calcified plaque. And this is concerning. We've seen this in our population at rampant levels. In our clinic, the average age is 42, as I mentioned. The median value of Lp(a) is 35% higher than the upper limit of normal. So more than half of our patients have elevated Lp(a). And when we do our calcium scores, I don't order them anymore, actually, because we have so many zero calcium scores and so much soft plaque that we uncover when we actually do the full CT angio. So we are seeing the importance of getting the anatomy as well as the non-traditional biomarkers and combining that into active aggressive therapies, and sometimes interventions, as we are able to uncover those things. So
fantastic. Burden of plaque, knowing that there's plaque, that is the substrate for progression to potential heart attacks. And as we highlighted, the tools that we have today, there's a lot of imprecision and among individuals with South Asian ancestry. So often directly imaging can be very helpful. There are a lot of comments. We talked a lot about BMI, waist to hip ratio. It may underestimate diabetes-related risk or metabolic risk in South Asians. There was a question, if it is elevated, maybe it's actually even worse for individuals who are South Asian. And so questions were, beyond diet and physical activity, what are other tools in the armament? And I'm looking to you, Dr. Gulati. What do we know about other tools, GLP-1 receptor agonists? When should people talk about that? What are those?
Yes, sorry, I was like answering questions on the side there. But well, we can start with we've talked a lot about obesity and what the difference is for the South Asian population, but GLP-1 receptor agonists, you're hearing all about them. Of course, they're all over the news. These are the drugs that at least are being touted related to weight loss. And certainly for weight loss, they're incredibly effective, but we also know that they're effective for people with certain forms of cardiovascular disease, some people who have heart failure, some people who already have had a cardiovascular event, who have excess weight. These drugs can be incredibly helpful. But in terms of what they do, by losing weight, they do also improve cardiovascular risk. So it's beyond just the weight. There's improvements that we see in the cholesterol, improvements we see in blood pressure, we see improvements in the glucose levels. And these drugs, we talk a lot about them as if they're new drugs, but actually we've been using these drugs for a long time in people who have diabetes. And so there may be some of you on this call here that have diabetes and were already placed on these drugs. It wasn't even necessarily about the weight loss, but that's where we found that our patients with diabetes were losing weight. And then the question came, could they be useful for people without diabetes? And they are incredibly useful, and they don't reduce glucose so severely that people are walking around hypoglycemic where their sugar is too low. But they are very effective tools that are very useful. The hardest part of using them right now in the United States has been access to them or coverage, getting insurance to cover them. And especially for the South Asian population, I've struggled with this because for South Asian, as we've all been talking about, the BMI measures are different, the waist circumference is different, but within what is categorized by our health insurances, they want a BMI of a certain value, that they don't care if you're South Asian. You can document it and say, for a South Asian, this is not normal or this is too high. And you won't always get a person on the other side of the phone that will agree with you that there needs to be a difference for them. So that's been a challenge, to sometimes accessing them for people that I'm identifying as higher risk, that I need to help them get on these medications. For any of you who travel over to India, I will tell you they're very cheap over there. And so you could bring your doses home if you're traveling. But very effective medications, as I said, more than weight loss, and especially what we are seeing in cardiovascular disease, that they're improving cardiovascular outcomes. If you have heart failure, they're reducing heart failure hospitalizations, particularly in people with a type of heart failure called heart failure with preserved ejection fraction, which is very strongly associated with excess weight. So there's also now some evidence that they improve kidney function in people with chronic kidney disease. So it's a really exciting time to be able to have these medications. And I will say that the whole weight loss medications it's just exploding. There's many drugs in the pipeline. There's drugs coming out. There's trials that are ongoing. I hope that that will drive down the price of these drugs and maybe even get better drugs over time that even have less side effects. So, I don't know what I was actually, you started me on the GLP, but was there
No,
something?
I mean, it's an exciting area. Increasingly, lots of evidence for cardiometabolic disease outcomes, specifically coronary artery disease. So diabetes medicine, that's increasingly being prescribed by cardiologists. And I'll just wind this up. I'll throw this to Dr. Palaniappan. We've covered a lot. So looking ahead for the next 5 to 10 years, what's the infrastructure that we need? What should we be doing? How should we invest our resources to solve this issue?
Well, thank you, Dr. Natarajan, and I want to really thank you for your leadership in bringing together the Our Health study. It is something that we have needed for decades, so thank you for being at the forefront of putting together a cohort of 10,000 South Asians where you collect genetic data as well as lifestyle data. And we really need to do this to fill the gap for all of the questions that you have about yourselves and your family members. And to be honest, every time any one of us opens up a medical textbook or an article, all we're seeing is European, non-Hispanic, white, Caucasian information. I encourage you to look at yourself at journals. Where are there South Asians represented? I was just returned from India, where I emphasize statins because that's where all of our evidence are. And they all raise their hands and say, we're dealing with high triglycerides and low HDL. What are the studies on that? And then I say, oh, well, there's no cardiovascular outcomes trials on fibrates, et cetera, et cetera. But they have not been done in South Asians, and we need to do that. So we need the resources from our community that has been so successful in the United States and worldwide. So I encourage you to support research so we can help you live longer, healthier lives. And all of this research is interpreted and brought to the community by programs like the South Asian Heart Center that Ashish Mathur leads. And he really has an innovative program now, and it is time to buy it, not build it. With South Asian Heart Center resources, they have a brilliant coaching model that has been in place for over a decade. And I encourage you to, sort of to utilize this resource in your own communities because it has been proven to be successful. So I will stop my comments there. Thanks, Dr. Natarajan.
Yeah, thank you so much for calling out the Our Health study. One thing I'll say, in addition to participating in the research through that study, a lot of the resources, a lot of the tips that you heard about today, thanks to Dr. Palaniappan's team, we've synthesized actually a lot of educational material, and a lot of this is coming from the South Asian Heart Center as well, that will be on that website as well. You actually don't even have to participate. You can just kind of put your email address on there, but we encourage you strongly to put in your information because, as we said, the concept, the notion of South Asian ancestry is so broad, so diffuse. We know that there are many different communities. There are going to be many community-specific drivers for cardiovascular disease. We see this overall thread, but we know that there is substantial heterogeneity, and that's largely driven anecdotally. But we need to collect the data to quantify it, just as Dr. Palaniappan had started this endeavor years ago. I do see actually a lot of the comments being addressed by Dr. Bhattacharya, one of my colleagues at MGH, who is the medical director for the Our Health study, leads the cardiometabolic lifestyle program also at MGH, and we have a lot of resources from there also on the website. So call out to you and thank you so much. So with that, we're just on time, maybe just a little bit over time. Thank you all for taking the additional time out of your day, a little bit over an hour out of your day. Hopefully you learned something. Hopefully you can bring this knowledge back to your families, back to your communities. And once again, thank you to Indiaspora, MR, and all of the staff. And MR, I'll throw it over to you in case you have any last comments before we close.
Sure. One thing I want to say is just all of you have done such great work for us this afternoon and evening in just demystifying a lot of the things to do with heart health. And the studies, the comments in chat, we'll try to synthesize that and broadcast it to our community through our newsletter as well and our website. But really want to thank all of you. This has been, I thought I would log off after introducing everyone, but I've been like totally in awe of all the details and the education that I've gotten in just an hour. Is just tells is a testimony to the hard work all of you have done. So I want to thank our former Surgeon General, Dr. Vivek Murthy, who's still on the call, and all of you panelists, Ashish Mathur, Martha, Lata, Rajesh. It's been a fabulous session. Thank you so much for doing such great work for our community. And I want to turn it over to our staff and thank our staff who've been leading this effort. Amita, come on up and say a few words to close this out.
Thank you, MR. Thank you, everyone. Dr. Natarajan, Dr. Mathur, Dr. Dash, Dr. Galati, and Dr. Lata. Thank you so much for your expertise. I do want to urge everyone to go to the website, check out the study, give of yourself to the database so we can build it out and make a more robust database for all of us. And MR, thank you again for this opportunity for, Indiaspora and doing all of this work for our community through this. So thank you, everyone. We hope you have a lovely evening. Bye.
Bye-bye.